right, thanks. I'd like the three panelists to come up to the front, and we're going to entertain questions. Alina, we'll start with you.
Great. Thank you. Thank you so much. This was really informative, and I know you all are on the front lines here, and I really appreciate all that you do. I'm trying to get a better sense of kind of where do STI, all of the STI programs fit within the larger responsibilities that you all have in terms of, that state health departments have and local health departments have in, protecting public health. I mean, this is a big charge. We've got clean water, environmental health. I mean, I know that, I've been to public health school. I understand all of those things. So I'm trying to understand, like, as the budgets are decreasing, my sense is that these are agency-wide budget cuts, and then how that filters down into the STI services, if you could elaborate on that a little bit. And then I do have one other question after that.
I'll start off. Yes, you're absolutely correct. I mean, at the state levels, jurisdictional levels, we do have a number of responsibilities. I think a lot of my counterparts, we do have a very strong focus on STIs. That's an advantage, perhaps, that we can really put a lot of focus into that. But I think maybe the discussion would get a little bit towards siloing, and that we still do have issues with that. I'll say that in my jurisdiction, and I think in others, it can be a challenge to work with other programs that are in the department because, as you indicated, they have other priorities as well. And more to that, working with upper administration to bring that to the forefront can be a challenge at times as well. I mean, when you're dealing with something else that perhaps has made more national news, whether it's a foodborne outbreak or Zika or what have you. Even though it's challenging, I do think a lot of us have come a long way in starting to change that narrative, or to get us maybe to be part of that communication. It really is about trying to get your face out there in the department, get your message out there in the department, and really help others understand how it is a related issue. And I think from my perspective, really trying to get the point across of how common they are. I mean, if there is an advantage to it, I mean, chlamydia is still the number one reportable condition in the United States, a number one reportable condition in every jurisdiction. So when we can kind of frame it that way and let folks know that indeed it's not just an isolated outbreak here and there, although that is something we need to address as well, I think that does help a bit. But I will admit, I do think there's a lot more work to do in that area.
Yeah, but just to get a sense, like in your state budget, like how much, in your state budget, the money that comes to run the health department in Iowa,
yes,
what share of that pie does your group get?
It's a great question. Very little. So the only support we have from, in my particular instance, from the state is enough funding that can help support our treatment programs for STD treatment medications, and a bit that can go towards testing. Proportionally, I mean, I haven't done the math, but I'm certain it's in the single digits for percents, and 1 or 2 around that range. And that's, you will see variability, but some states certainly have a lot more support with perhaps more forward-thinking legislatures. But some have less, some have none. I think I mentioned that it's very common for all of the support for an STD program to come from CDC and really nothing else.
For state health agencies, about 48% of budgets come from federal agencies. So we are largely reliant on funding from CDC for STI programs. There is some variation in terms of the way states are able to leverage other program funding to support STI programs, and some states also have state level funding that they direct towards their STI programs. We're actually getting ready to do a data collection on what that variability and makeup looks like across the U.S. But for the most part, a lot of it is reliant on CDC funding. And then, like I said, within health agencies, there are a number of competing priorities. And I think the key for our health commissioners is, as much as possible, to make that linkage with those other high priority subject areas, so we make it easy for them to act and we make it easy for them to integrate their approaches.
I'd say, it's definitely hard to quantify, particularly at the local level. It can be really hard to quantify where funding is coming from and the proportion that is designated to one particular issue. When we ask local health departments, how are your STD prevention activities funded, the nuances of where the funding is coming from are not always readily available. Yeah. I will go back to look if there is anything from our profile study or the infrastructure survey that I referred to that could help address some of this more concretely than what I'll share next, which is a little bit just more anecdotal, but to say that, as I mentioned, so much of our STD work is happening in partnership with our members, and we've had a number of opportunities to put out requests for proposals to work with us on various projects, and there's always a significant amount of interest. Or when at NACHO's annual meeting and I introduce myself to local health officials, it is something that our local health officials really are quite interested in engaging in. And I think a recognition that there are very core public health services and responsibilities as it relates to addressing the STI crisis and the commitment around that. And then lastly, I just wanted to note that there are a number of jurisdictions that are really looking to connect what is happening with the STI crisis, really focusing in on health disparities and addressing that through some of their health equity work. And I think that's very illustrative of the commitment to addressing this crisis.
Great. And then just as a quick follow-up, I do a lot of work on women's reproductive health and have been working very closely on a lot of the Title X issues. And I see a lot of parallels, a program that really has increased demand but not increased funds. And I also wondered, what's the kind of relationship that your health departments have with kind of different Title X family planning agencies, federally qualified health centers that I think are kind of on the front lines with providing a lot of those services that when health departments no longer do that?
So I'll start off because I actually feel very strongly about this topic that you've just raised. It is crucial to our work in STI prevention, those partnerships. In my jurisdiction, we work very closely with our Title X and other family planning partners. The network of clinics that we have that provide safety net or STD specialty services, we have about 58 across the state, which may sound like a lot, but as was mentioned earlier, some of those are open for like couple hours a week or something. But my point is that half of those are family planning agencies. At one presentation I did, I showed a map of our state, like with all the clinics, all the safety net and specialty clinics, and then one without Title X included, and our state looked desolate. It was horrendous. So I feel very strongly about those partnerships. We could not do anywhere near the level of testing and outreach. And it's not just testing, it's connecting folks with other needed services that are identified during those visits. We also referenced FQHCs. We work very closely with them as well. We have a number of them in our state that are part of that program. And I know that's pretty common throughout other jurisdictions as well. So, I just cannot speak enough into how valuable I think those partnerships are.
So we're going to go 3 more questions. Jeff Crowley, and then John Schneider, and then Ned Hook.
So you paint a somewhat bleak picture, and it seems implicit that you really think we need more resources, but they're going to come from the feds. But, our framers' conception wasn't that the feds would provide the money and states would have the control and the flexibility. It's that the states would finance it. Do we just need to give up on the idea that the states could ever, or local governments, really contribute more resources here? And let's say we got a dream that came true and we got it. How would we get STIs prioritized? Like, Elizabeth, you made some great points about competing priorities, and I think you said we need to sort of tack on, as part of the opioid response. is there nothing we can do to just convince your bosses essentially that STIs on their own deserve to be prioritized, or is there a case that you think we could make there that we could understand to really elevate this as a priority?
Well, I think from our members' perspective, STIs are very concerning. We're seeing really alarming rates, large disparities. So I would say that they are a priority for our health officials. I think when you're working with limited budgets, we need to think about how to integrate our activities across those programs. So I think the point I was making about trying to link it with other high priority topics that are already getting a lot of attention is mainly due to that reality that they are working with limited resources and capacity. I think I can't speak very well to the contributions at the state level to STI programs, but like I said, we are embarking on a new research effort to take a closer look at that, because I think that really is a key part of this conversation, understanding what are those state level contributions, and I think it will vary across the board. And I think, unfortunately, for some health agencies and state contexts, we might be dealing with a context where there really aren't resources at the state level to increase this. So unless we see larger attention on this at the national level, I don't anticipate any changes on that regard.
I would just add to that the role of our members, the local health officials and the state health officials, in terms of determining their budgets. It stops at some point in terms of the budget that they are given. And so the work of advocacy and engaging community to advocate state and local decision makers and policy makers to increase the budgets to local health departments. I think equipping local health officials and other staff within health departments and state health officials, STD program directors, with the tools, the resources, the talking points to help make the case for why is it so critical that additional resources be made available to address this urgent crisis, and how does this affect the health of the entirety of our community. And absolutely, whether it's the opioid epidemic and other high-risk substance use, the Ending the HIV Epidemic Initiative, looking at those opportunities to help make that comprehensive case about STIs are a component of overall health, not a separate entity.
And just to add, I think what Gretchen mentioned kind of keyed something off for me as well. A lot of what ASTO's work currently on STIs looks like right now is in developing some of those communication tools to raise awareness amongst our members in areas where there might need awareness raising, but also to arm them with the messages and communication resources to help them communicate with their constituencies, whether it's the public or other decision makers at the state level. So I mentioned the fact sheet that we did jointly with NCSD that features outputs from the CDC's Space Monkey tool that shows how program investments really do have an impact on health outcomes and bottom line medical spending. And those resources are just invaluable. We need more of those economic analyses for our health officials to make the case at the state level, in addition to in national context, to show what the real burden of disease looks like, what the health outcomes and impact of that look like, in addition to the economic outcomes as well.
Just briefly, I'll say I couldn't agree with those two comments more. NCSD also does a lot of work in this area. There's a policy academy that members can go through, and that really helps empower them to be able to better talk to legislators, decision makers, and really educate them as opposed to lobbying. To kind of directly answer your question, I think you asked, there's a bleak picture. Should we just give up on localities giving anything to this? And I don't think so. I think the comments of my co-panelists are really how we're going to get there is really trying to make that case, show that federal agencies, the federal government is taking it seriously, will help. I think underlying all of this is that it does need to be a broad effort. What I would caution against is trying to replace one for the other. So, federal government can't get enough money to support testing, so let's just put it all in the states. That's not going to work. But if we can kind of have this kind of longer arc, longer vision, I think maybe over time we could get there. I would just be very concerned about very quickly saying one's going to replace the other. So I really think we need more of a buffet of options than trying to trade out.
All right. John?
Thank you for that. I was thinking about, I think, Elizabeth, you mentioned DIS and partner services type activities, and also this idea of kind of cutting across different programs. Can you all speak to how, sort of maybe syphilis DIS has, how does HIV and syphilis DIS, how has it worked? How has it not worked when programs are getting integrated? Are there statutory issues as far as people being able to use resources from we're seeing a lot of decline in HIV cases, right? So the thinking is maybe that can be shifted elsewhere. Can you speak a little bit to that?
I'll start off. So many programs, STD programs, have had to integrate HIV and STI just out of necessity. We did not have the luxury of having separate DIS because we didn't have the resources to do that. So many local jurisdictions and states are used to doing that. So we haven't really been tripping over each other with that. And I'd say it's worked very well. As far as information sharing, resource sharing, that has evolved over time. When I started in this position, I knew it was very common to be difficult for HIV partners to share information with us, particularly HIV surveillance. And we were doing the HIV partner services, but we were running into some problems because they felt like they couldn't share those data. But again, with efforts at the local level and efforts from CDC to really clarify that was acceptable and provide guidance on that has come a long way and helped. Resources is complicated, financial resources. It really depends on your perspective. I mean, you can do a half full or half empty look at this. There are a lot of programs, STD programs, that benefit very greatly from resources from, let's say, Ryan White, HIV prevention, that pay for a significant proportion of DIS, and in some cases, the majority of DIS within certain jurisdictions. So that shows that we are able to share resources and things are going very well. But I still feel like there's a long way to go. A lot of us experience pushback when we're trying to do things around testing or anything with media or to raise awareness with media campaigns and things like that because of the regulations that they have. If you use Ryan White, for example, I mean, it really should be geared towards folks that are living with HIV. And sure, there's significant overlap, and we can find ways to do that. But there are some differences in somebody who is at risk for an STI and does not have HIV, and one who is living with HIV and contracts an STI. Yeah, I'd say there's more work to do. I am happy that we've come a ways, but it has been an incremental change.
Short answers and short questions. Go ahead.
Yeah, just a short answer to that. So, I mean, Gail talked about it this morning, but really also thinking about the role of DIS beyond HIV and STI, as well as in the linkage and the overall role that that DIS have to play in both public health and healthcare systems and linking these systems and services for individuals. I think another important piece about DIS is that they are often called on to respond to public health emergencies. And so when we did the enumeration of the DIS, we also asked, how often have you been called on to respond to a public health emergency? Or we know that DIS from all across the country went to Scott County, Indiana, to support the response there to the HIV outbreak. And I think bringing more of those stories to light and really understanding the role that this very critical component of the STI workforce is for the overall public health and healthcare systems and workforce.
Very good point. Telling stories is often something that is more compelling than data in certain audiences. So Dr. Hook, and then finally Dr. Kissinger, then we'll have to move on. Short questions, short answer.
Thank you for your comments. I'm interested in this issue of integration of HIV and STI services beyond DIS. First of all, do you have a a sense of the proportion of health departments and jurisdictions which have integrated versus which have not. Second part of the question is, in this era of declining purchasing power, at the very least, the pie doesn't get any larger. You have to make prioritization. And I have a sense of who gets the short straw, but I'd like to hear some comments in that direction as well.
I'll speak to the integration piece to say that I don't have those numbers for you offhand, but as a part of a lot of the survey work that we've done, both around the engagement and PrEP implementation and then the infrastructure survey, we do specifically ask about the integration of HIV and STD programs. So I can follow up with the committee with that information.
I'll briefly add, I don't have those numbers with me either. I would say the majority are integrated, but I think a key question is, what do you mean by integration? Because if you ask an HIV person what's integration, an STD person, those can mean different things. So I'd caution you to clarify that.
Why don't you expand on that a little bit?
Put me on the spot, huh? Well, I think it goes to your second question, and who gets the short end of the straw. Quite frankly, when you talk about integration from an HIV perspective, I think it's an STD program or persons going and saying, please, sir, can I have another? And the HIV program saying, oh, yeah, sure, we'll give you a little something to help with this or that, this one-off thing, or, if you're talking beyond DIS. So to me, it would be more of a partnership decision when looking at programs across the state and priorities across the state, as opposed to STD often comes in second, quite frankly.
Okay, quick question. So maybe it's not a quick question, but since most of the STDs are diagnosed in the private sector, what's your interface with the private sector, or who is interfacing with them?
So yeah, we interact with the private sector very frequently. But, a lot of that is case reports coming in. And we work with them on consultations when they're not sure how to treat an STI. I can't say that it's like I have regular meetings with the private sector. We're getting better at that. We're working with our actually local health departments because they have better connections, quite frankly, than we do at the state to have those inroads. But it exists, but I guess, again, it goes back to definitions and how would you... What's a threshold for saying that you have a high level of interaction?
We do, I believe, have data in the profile survey about partnerships, and I'll have to check if we enumerate partnerships with the private sector. I will say that, a model that I'm sure a number of you are aware of is the model of public health detailing or academic detailing. So having health department staff go and detail providers in their communities to provide education and information about critical issues. We've seen great detailing campaigns around EPT, PrEP, implementation of STI testing. And so I think that is a way to really leverage the interaction with private providers and think about how public health can work with that community.
Talking a little bit more on the policy level. So, for example, if you wanted to get private sector to implement chlamydia screening or to engage in EPT, do you do that, or is that even possible?
We do. I'd say with very limited success. I think that often comes down to the competing priorities. It can be hard to even get a meeting or an audience with somebody in the private sector. We've tried to take the strategy, and I know NCSD has supported this as well, of trying to work with larger systems, work with insurers. And again, that is variable by your jurisdiction as to how successful you are and if you can kind of get your foot in the door. From my personal experience, we had some very early success. There were some significant changes in leadership, and it's very hard to get an audience now. So I think, it often comes down to we're kind of asking them to do something, not really able to give any kind of incentive or give anything other than expertise. And although that's important and we value that, I don't know how valued it is from their perspective.
Very helpful. Oh, go ahead.
I think an important piece there too, though, is in terms of making the cases, we're here representing organizations whose membership is the governmental public health entities and thinking about engaging those associations and groups that are representing providers in their communities and really ensuring that it is elevated to a priority level within those bodies.
All right. Thank you very much. Much appreciated.